Elamipretide for the treatment of primary mitochondrial myopathy. The third talk will be by Will Cho on REN001 or Mavodelpar for primary mitochondrial myopathies. And the fourth talk will be by Susan Van Meter from UCB on TK2 deficiency. So I will just start. And these are my financial disclosures. I do want to reveal that I do have intellectual property, and I'm a co-inventor on a patent for a therapy for TK2, which will be discussed. So, all right, and I'm going to cover mitochondrial myopathies and try to convince you that mitochondrial myopathies are a good target for therapeutic interventions. So as you know, mitochondria are essential organelles for producing energy through oxidative phosphorylation and providing the ATP energy that drives all of the functions of all of our cells in our body. So it's not surprising that mitochondrial disorders are typically multisystemic disorders, as shown here. Nevertheless, myopathy is a very frequent manifestation of mitochondrial disease. In our North American Mitochondrial Disease Consortium, about 3/4 of the patients have myopathy. So it's a common denominator among many of our patients with mitochondrial disease. So I think that's one reason why this is a good target for therapeutic intervention. Another reason is that it's a frequent complaint of mitochondrial disease patients. This was a survey taken by Zuela Zell-Kipling-Cunningham, a survey of patients with a variety of mitochondrial disease to determine what it would motivate and prevent them from participating in clinical trials. And we'll talk about the motivations. So they reported that they had an average of 16 symptoms in each patient. That's a lot of symptoms. And if we were to do trials and try to measure all of those symptoms, it would be impossible. So we have to try to focus that. So the top 3 symptoms that they experienced and that were prioritized that would drive them to go into trials are muscle fatigue, chronic fatigue, and exercise intolerance. They're all muscle related. So it's not only common in the mitochondrial disease community, but it's also a major complaint. The 3 top major complaints for which they would participate in trials are muscle related. So I think muscle is really important. And for this audience, it's very relevant, obviously, for Muscular Dystrophies Association. So I think for these reasons, muscle is a very good target for mitochondrial disease therapies. All right, and I want to highlight this paper by Tanya Tavasalo and Ron Haller and Doug Pernbel showing that we can already intervene with exercise therapy and improve muscle functions. And this was a study that she did in Newcastle where they trained people to do aerobic exercise for 14 weeks, and then patients were randomized into either stopping the training or continuing the training for an additional 14 weeks. And this was a small group of 8 patients with Kearns-Sayre syndrome, one of the classic mitochondrial disorders. And what was remarkable is after 14 weeks of training, they showed improvements in peak exercise capacity, O2 utilization at peak, and peak O2 extraction. And that improvement, when they stopped exercising, reversed. So as you can see on the right panel here, this is after the first 14 weeks. You can see improvements that declined in those who stopped exercising and improved after 14 more, or stabilized in the patients who had done 14 more weeks. And not only did it improve these functions on exercise physiology testing, but also measurable improvements and significant improvements in the quality of life of these patients. So this shows that not only is myopathy an important issue in these patients, but it's potentially improvable or reversible in patients with mitochondrial myopathy. So it's great, but not all of our patients with mitochondrial disease can exercise. There's a window of opportunity to do that, because if they become too weak, they will stop, they won't do it. And it would be great, instead of having to tell people to exercise, that if we could give them a pill to get the benefits of exercise without doing the exercise, that might be even better. So we're looking to the pharma industry to help us develop pills, not only for patients with mitochondrial myopathy. I think many of us would like to take a pill and have the benefits of exercise. All right, so what is a mitochondrial myopathy? We had a workshop a few years ago where a group of us got together and in Rome and discussed what are primary mitochondrial myopathies. And so we define these as mitochondrial diseases that are genetically defined. So you have to have a genetic diagnosis that causes a defect of oxidative phosphorylation that affects predominantly but not exclusively skeletal muscle. So for example, Kearns-Sayre syndrome, of course, skeletal muscle is affected, but the extraocular muscles are affected, as well as the retina with pigmentary retinopathy. So that's an example of primarily mitochondrial myopathy, but other organs are affected. And these myopathies can affect patients at any age with generalized weakness, often presenting early in life, but it can present at all ages through adulthood initially. And they sometimes affect specific muscles, particularly extraocular muscles, but limb muscles are frequently a target. And one feature of mitochondrial myopathies that's different from your average muscular dystrophy is that the patients often complain of exercise intolerance out of proportion to their weakness. So they may have mild weakness on exam, but they'll have trouble walking up a flight of stairs. They'll get short of breath, their muscles will ache and burn because they're not making ATP energy. So exercise capacity is limited not just by weakness, but also by the lack of ATP synthesis. And the most common clinical manifestation of these mitochondrial myopathies is progressive external ophthalmoplegia, in addition to the limb muscle weakness and exercise intolerance. So these are some of the trials that have been completed or are ongoing, and we're going to hear more about some of these trials in this session, but just to highlight that there have been some trials that have already been completed. Bezafibrate actually is completed, but we don't know about the results of that study in patients with the 3243 mutation that causes MELAS. We've heard about this RT408 in the context of Friedreich's disease, omavaloxolone. That's the therapy that was just approved for Friedreich's ataxia, and a trial has been done in mitochondrial myopathy, but in that trial, they used lower doses than were used in Friedreich. So it would be great if this company could go back and perhaps re-examine this drug in the context of a higher dose. We're going to hear more about Elamipretide. So I'm not going to say much more except to say that there were some phase 1, 2, and 3 studies, but we're going to hear about their newest phase 3 study. We're going to hear also about the REN001 trial, which is the PPAR delta modulator, and finally the TK2 deficiency deoxynucleoside therapy. So we're going to hear more about these specific trials. And so I do want to highlight there's the United Mitochondrial Disease Foundation is offering a free genetic testing program, which is sponsored actually by a pharma industry partner. And this is available for all clinicians in the United States, and they have to have a primary clinical diagnosis consistent with primary mitochondrial disease, and they cannot have had whole exome or whole genome sequencing prior. But these are specifically for patients who have a high suspicion of mitochondrial disease without insurance or insurance that doesn't cover the testing, and you can see the website where you can get that testing, where you can order kits for that testing. And it's done in a CLIA-certified commercial laboratory. So that's, you have to have a diagnosis genetic diagnosis to participate in any of these trials. All right. Oops, and just go, I lost the last slide, but the last slide was just the titles and the names of the people who are going to speak in this particular order. Actually, yes. So actually, I think my slide is out of order as well, but I think Anthony Abruzzo, okay, Abruzcato will give the next talk.
All right, good afternoon, everyone. My name is Anthony Abruzcato. I'm the Vice President of Clinical Development at Stealth Biotherapeutics. I want to thank MDA and Dr. Hirano for organizing this session. I'm very enthusiastic to see the growing presence of clinical research in PMM. So just a little bit of background on Stealth Biotherapeutics as a company. We focus on mitochondrial medicine. Our pipeline is broadly organized into 3 therapeutic franchises. We have a cardiology franchise, an ophthalmology franchise, and a neuromuscular franchise. And you can see with our lead asset, Elamipretide, we have a number of late-stage assets in clinical trials currently, and we'll focus today on our program in PMM. So a little bit of background on the mechanism of action for Elamipretide. As indicated in the previous slide that Dr. Hirano showed, our target is cardiolipin. So cardiolipin is a phospholipid that is found predominantly in the inner mitochondrial membrane. And cardiolipin has 4 acyl chains that promote this canonical structure that's really important for maintaining that curved shape of the inner mitochondrial membrane, the folds of the IMM called the cristae. And that structure is really important for proper mitochondrial function. So those curves keep the complexes of the electron transport chain in the proper orientation to efficiently shuttle electrons and produce ATP. And across a variety of disease pathologies, cardiolipin is very prone to oxidative damage. And when cardiolipin is damaged, you lose that proper structure and therefore function and ability to produce ATP. And this can also lead to cell death. So Elamipretide is a positively charged tetrapeptide that localizes to the inner mitochondrial membrane, interacts electrostatically with cardiolipin, and helps to restore the proper morphology of that inner mitochondrial membrane while also preventing cardiolipin from oxidative damage. And we'll talk a little bit more about the mechanism relevant to PMM specifically in a few slides. So also, as Dr. Hirano mentioned, we have a good amount of experience in PMM. This is our longest standing clinical development program, a number of early phase trials. We've generated a lot of data, a lot of lessons learned throughout this program, and I'll share some of those key insights with you all, particularly as it relates to our phase 3 program. So we previously completed the MMPower 3 study, and the insights from that study helped set the stage for our current phase 3 trial, the NuPOWER trial, which is actively enrolling. And this is a trial in patients with PMM resulting from pathogenic nuclear DNA mutations. So the MMPower 3 study, this study was completed a few years back, was a global phase 3 randomized placebo-controlled trial enrolling 218 patients with primary mitochondrial myopathy. Patients were enrolled in a 1-to-1 manner to receive Elamipretide 40 milligrams or placebo via daily subcutaneous injection rotated around the abdomen. Patients then followed on into an open-label treatment extension. This study had a family of primary endpoints, so we were looking particularly at the change from baseline in the 6-minute walk test distance, as well as the change from baseline in the total fatigue score on the PMM Symptom Assessment Questionnaire. So MMPower 3 was designed as a basket trial, so all patients had a diagnosis of PMM, but the underlying genotype was quite variable. As you can see here, about 3/4 of the patient population had mutations in mitochondrial DNA, and about 1/4 of the patients had mutations in nuclear DNA. So a lot of genetic heterogeneity included in this trial. And just to further break that down visually, again, you can see the breakdown of the underlying genotypes in this study. Mitochondrial DNA mutations are shown in shades of gray, and nuclear DNA mutations are shown in shades of green. In the mitoDNA group, the largest cohort of patients had mutations in NTTL1 associated with Melas syndrome, followed by large-scale mtDNA deletions. In the nuclear DNA subgroup, the most common genetic mutation was of the POLG polymerase gamma gene. So this trial didn't meet either of its primary endpoints. But the story gets a bit more interesting when we look at the different DNA subgroups. These were pre-specified subgroup analyses. And on the left on this slide, you can see that for the mitochondrial DNA subgroup, again, no statistically significant difference between treatment or placebo. We even saw evidence of a pretty strong placebo response. Patients on placebo walked about 25 meters more than baseline at the end of the trial. However, in the nuclear DNA mutation subgroup, we see a more striking treatment effect, about a 24-meter difference between treatment and placebo favoring Elamipretide, and really not much of a placebo response in this subgroup. So we really wanted to understand this potential signal a bit better. One supporting analysis that gives us confidence in this subgroup finding was an exposure response pharmacokinetic analysis done. So this graphic here shows you the change in 6-minute walk test as a function of the plasma area under the curve. And you can see the correlation. It's a modest correlation, but it is statistically significant. So this was a key insight from the trial, because what it tells us is supports the subgroup finding is not something that's likely to happen by chance alone. Otherwise, we wouldn't have seen this relationship. And it also suggests that the therapeutic dose may not be optimized. So we may have room to go up beyond 40 milligrams to optimize efficacy, response to Elamipretide. So again, with this subgroup finding, we really want to hone in and understand on who's responding to therapy and who's not. So this is a similar stack chart to the one I showed previously, but this focuses specifically on the nuclear DNA mutation subgroup. And what we noticed that most patients who had a pronounced response to Elamipretide on the 6-minute walk test had mutations in genes that encode for proteins influencing either mitochondrial DNA replication or the maintenance of the mitochondrial DNA nucleotide pool. So again, trying to understand the relevance of this back to our mechanism of action. And beyond just maintaining the proper structure of the inner mitochondrial membrane, cardiolipin also plays a really important role in other mitochondrial dynamics. So almost all mitochondrial proteins are encoded by nuclear genes. So those proteins have to be imported into the mitochondria, and that is a process that's very dependent on cardiolipin for that protein importation. And specifically to mitochondrial DNA replication, mitoDNA replication occurs in clustered nucleoids, and those nucleoids need to associate with the inner mitochondrial membrane, and that association is also mediated by cardiolipin. So again, when cardiolipin is damaged, there's a reduced ability for mitoDNA to actually replicate. So that's what we think is kind of the genotypic common ground for all those mutations that we believe responded best to treatment with Elamipretide. So as Dr. Hirano pointed out, there's also a pretty broad range of phenotypic heterogeneity in primary mitochondrial myopathy as well. And this graphic on the slide here is really just an illustration using polymerase gamma-related disorders as an example. But you can see the same genotype can vary quite a bit based on the age of onset, where patients with early onset have more of the central nervous system manifestations, and patients with late onset disease have more of the myopathy phenotype and PEO. And I don't have the data shown in the slide deck, but again, when we looked at the phenotypic characteristics of the treatment responders from our previous phase 3 trial, we saw that patients who responded best to treatment tended to have an older age of onset, and they had the comorbidity of PEO. So when we combine the learnings from the genotype and the phenotype analysis, this is a post hoc now analysis from our previous phase 3 trial. So this is showing the patients with nuclear DNA mutations of the mitochondrial replisome plus the comorbidity of CPEO. And this is a post hoc analysis, so it should be interpreted with caution, but we see a striking difference between treatment and placebo of about 45 meters. Again, nominally significant p-value. So this is really what set the stage for where we are today for our NuPOWER phase 3 clinical trial, which is actively enrolling. So this is a phase 3 randomized double-blind placebo-controlled trial in patients with PMM resulting from pathogenic nuclear DNA mutations. It's a similar trial design, 1-to-1 randomization, You can see that for this trial, we are increasing the dose from 40 to 60 milligrams, again, based on our pharmacokinetic exposure response analysis. And on the next slide, just some of the key inclusion criteria for this trial. Again, we're focusing on adult patients with PMM. We included the comorbidity of PEO based on again, the post-hoc analysis of our previous trial. And we're focusing primarily on those genes related to mitochondrial DNA replication or maintenance, and those genes are defined here. So the endpoints for this trial, again, we're sticking with the 6-minute walk test as our primary endpoint, but we're also including other functional measures, time testing, such as the 5-time sit-to-stand test and the triple-timed up and go test. And we have a number of patient-reported outcomes and biomarkers in this trial as well. And just to wrap up with some lessons learned here, for Elamipretide, nuclear-encoded control of mitochondrial DNA maintenance and replication may have particular relevance for our mechanism of action in this patient population. The basket trial, while it gave us tons of invaluable data and information, introduced a lot of heterogeneity that may have ultimately compromised the ability to see a treatment effect overall. And furthermore, exposure-response relationships may vary based on the genotype-phenotype as well. So there remains a high unmet need in the patient population. Again, delighted to see more sponsored research in the space. And for us, we're just very thankful for all of our collaborations with the patient advocacy, investigators, site staff, thought leaders, and everyone who helps us advance this program and development. And with that, I want to thank you for your attention.
Maybe take a question or two?
Questions? I think we'll take a few questions if we have time.
Thank you. Hi. So with your primary outcome endpoint of the 6-minute walk, have you considered something more physiological? The patients pace themselves, and if you're wanting to see whether your intervention is improving their exercise intolerance, you need to be able to push them to see that. And I don't know if you're familiar with there's a study done in DMD, boys where they were given, as a $50 if they could walk further, and, they walked 41 meters further. And so that's an amazing result. And so I just really encourage, for such important phase 3 trials where you're looking at an intervention effect on a mitochondrial-based measurement, to, include some more physiology. You can look at heart rate, for example.
Yep.
Lactate levels, finger pricks, something like that.
Yeah. Thank you for that commentary. Very good points on the challenge of the 6-minute walk test. It is subject to effort dependence. We will take that under consideration. We are sticking with it as the primary endpoint just to follow the signal. It's kind of hard to deviate that from that as our primary endpoint at this stage in development, but your points are absolutely noted on the challenges with it.
Okay, great. So I think maybe we'll give people the opportunity to think of more questions, and we'll go to the next speaker. Will?
It's his slide. It's his slide.
It's the wrong slide deck. Can we switch the slide deck?
Great, thanks. Hello, everyone. My name is Will Chow. I'm a Vice President in Clinical Development Medical Affairs at Reneo Pharmaceuticals. And on behalf of Reneo, I'd like to thank the Muscular Dystrophy Association, as well as Professor Hirano for inviting us here today so I can give you a brief overview of our current development program in PMM. Just first, a couple of disclaimers. First, I'm an employee of Reneo, but the most important disclaimer in the subject of today's talk is our molecule Mavodelpar, which is currently an investigational therapeutic in clinical trials. It has not been approved by any regulatory agency. Okay, so a quick overview of Mavodelpar. That's the chemical name. It was formerly known as REN-001. As you can see, Mavodelpar is a chemistry-based drug candidate that's intended for once daily oral administration, either in capsule or tablet form. What its mechanism of action is, it's an agonist of PPAR delta. And in turn, what is PPAR delta? Well, PPAR delta, similar to its other two isoforms of PPARs, it is a transcription factor that regulates several genes known to be associated with metabolism, and in particular, PPAR deltas are known to increase the transcription of genes not only related to mitochondrial function, but also mitochondrial biogenesis, and even more specifically, fatty acid oxidation. So this slide here is just illustrates a time course of how tissues and cells in the body respond to energy needs over time. So, when a burst of activity is required by, say, the skeletal muscles in the first couple of seconds or so, the principal source of energy, it comes in the form of phosphocreatine reservoir, where it can donate a phosphate to ADP to generate ATP in the first couple of seconds. Thereafter, carbohydrates, and more specifically glucose, become the principal source of energy, either anaerobically or aerobically. And then over time, fatty acids take over as the principal source of generating ATP through the cell's mitochondria. This slide is also somewhat relevant to the reason why in our current ongoing pivotal trial, we decided to use a 12-minute walk test as our primary endpoint as opposed to the 6-minute walk test. And I will get into that a little bit further. There's also a slide that I'm going to show from an earlier study that was a single-arm open label study where we looked at walking velocity. So just keep this slide in mind as far as the time course of different nutrients and how ATP is generated, because I'm going to touch on that a little in a couple of subsequent slides. But I think somebody asked the question in the previous presentation about the different walk tests, and I think it's a great question. I wanted to also emphasize that our 6-minute walk test is intended as a maximal test of endurance. It's in other studies and different indications, this 12-minute walk test could be used as a submax test, but here in our trial, the instructions to the subjects are to walk as briskly as possible for 12 minutes. Okay, so just a brief overview of kind of our company pipeline. There's 2 indications that we're currently pursuing. Our lead indication, as I mentioned, is PMM, and we have a second indication that has finished an open label study in long-chain fatty acid oxidation disorders. So that would be our second intended indication. I'll get into some of these milestones in a future slide. Okay, so before I dive into PMM, I wanted to briefly summarize an earlier proof of concept study where we tried to look at tried to answer the question whether Mavodelpar could maintain or even possibly improve muscle strength. So this is the leg immobilization study that was done in adult healthy volunteers. So these are not PMM patients, but they, again, adult healthy volunteers. This was a randomized double-blind placebo-controlled study that enrolled 24 subjects. So 12 of them were randomized to receive active drug and 12 received placebo. The duration of this study was 28 days. So there was 28 days of dosing. At baseline, the subjects they had their leg immobilized through a knee brace. So they were essentially sedentary. They could get around using crutches, but the intent was to see, first induce some kind of muscle atrophy with 14 days of knee brace immobilization. And then after day 14, the brace was removed, and then there was a variety of muscle strength testing, principally through knee extension exercises. So the primary objective was to evaluate safety and tolerability of 28 days of dosing, and then the secondary objectives were to look at changes in muscle strength and function after day 14, when the leg brace was removed. Okay, so with respect to safety and tolerability, Mavodelpar was well tolerated. The incidence of adverse events between the active drug arm and placebo were very similar. Now, with respect to the muscle strength evaluations, you can see here that 1 hour after removing the brace on day 14, there was relative preservation of muscle strength in the Mavodelpar purple arm versus the placebo arm, which lost strength as would be expected after 14 days of immobilization. But then a week after the knee brace was removed, so this is day 21, here you see that there's actually an increase in knee extension strength relative to the placebo. So immediately afterwards, again, relative preservation, and then day 21, a relative increase in strength. Now, another thing we looked at in this study were changes in gene expression through muscle biopsies. And what's shown here in this figure are placebo-corrected changes in gene expression of 3 different genes that are known to be associated with various aspects of mitochondrial function and fatty acid oxidation. These genes are PDK4, ANGPTL4, SLC25A34. You can see here that there was a placebo-corrected increase in the expression of these genes all the way out to day 29, with ANGPTL4 being the most prominent. Okay, I think Dr. Hirano did a great job covering primary mitochondrial myopathy, so I'm not going to repeat everything that he said. I'll just make note that PMMs, even as the prior presentation mentioned, they can be caused by either mutations or defects in either mitochondrial DNA or nuclear DNA. The estimated prevalence in PMM between these two kinds of genomes are about 70 to 80% that are attributable to mitochondrial DNA defects versus 20 to 30% attributable to nuclear DNA defects. The overall prevalence is estimated to be anywhere from 1 to 5,000 or 1 to 4,000 patients with PMM. And as Dr. Hirano said, the disease can be quite heterogeneous and can affect patients at different ages. Importantly, there's no currently approved therapies for primary mitochondrial myopathy. The standard of care tends to be vitamin supplements or so-called mitococktails, and then physical therapy and other forms of exercise therapy. So there clearly is a big unmet medical need for an approved therapy in this area. Okay, so this phase 1B study was the first study that we performed in an actual disease population. I mentioned that this was a single-arm open-label study, so you have to keep that in mind as a limitation. Here we studied in 23 patients, dosing up to 12 weeks. The study was originally intended as a 48-week study, but this occurred during the COVID pandemic, and it was conducted at a couple of sites in the United Kingdom. So because of the general COVID pandemic, there was a need to prioritize patient safety in general, and so that's why this study didn't actually fully complete the Part B that was intended. Part B was this 36-week optional extension. But out of the 23 patients who enrolled in Part A, 17 of them did complete 12 weeks of dosing, for which we have safety and efficacy data. So as far as, we looked at several different exploratory efficacy endpoints in this, the first being the 12-minute walk test. So out of 17 patients who completed 12 weeks of dosing, you can see that their baseline 12-minute walk distance was about 600 meters. At the end of week 12, they increased their walking distance over 12 minutes by approximately 100 meters, more specifically 104.4 meters. The 95% confidence interval is provided here. Again, there's not a placebo arm, so I just want to, mention that as a limitation. But also, if you look at the number of subjects out of these 17 who showed an increase from baseline, you can see this here in this bar chart. And what's interesting is that quite a few patients were able to walk greater than 100 meters from their baseline distance. Of course, without a control arm, there's always the question of how much of this could be attributable to a learning effect. But anyway, this data was very encouraging, and also 13 out of the 17 patients had an increase of 50 meters or more. Now, we also looked at walking velocity in this study. Here, the key takeaways are, in the placebo arm, you can see that there's a decrease in walking velocity at each 3-minute period. So there's 4 3-minute periods over 12 minutes. You can see that this line gradually goes down, the placebo arm. Whereas, not the placebo arm, but the baseline. At baseline, the walking velocity goes down with each subsequent 3-minute period. Now, at week 12, the walking velocity initially goes down, but then tends to somewhat stabilize between the last 2 3-minute periods. And this is interesting because if you think about that earlier slide that I showed about the time course of how different nutrients, carbohydrates, fatty acids, et cetera, contribute to ATP synthesis, this kind of somewhat supports the notion that as fatty acids become more of a contributor to ATP generation by the mitochondria, that this perhaps reflects a bit of that going on. Again, it's not proof of that, but it's interesting finding here. Now, we also looked at VO2 max as another efficacy endpoint. At baseline, the peak VO2 was 14.6, which increased to 16.3 at week 12. Again, there was not a placebo control arm here, but the mean increase from baseline was about 1.7, and you can see the confidence interval here. And similar to the 12-minute walk test, the majority of patients did show an increase from baseline in their peak VO2 at 12 weeks. Finally, we also looked at a variety of patient-reported outcomes, focusing on symptoms of fatigue and pain. Here, you can see their baseline scores for these instruments, being the SF-36 energy subscale, the MFIS, and then the BPI. In the case of the SF-36, a higher score is better, meaning there's less fatigue, whereas in these two instruments, a lower score is better, meaning less fatigue or less pain. And you can see that we saw encouraging increases in the fatigue score in the SF-36, as well as encouraging decreases in MFIS and BPI at week 12 versus baseline. And then finally, there was also a subset of patients who got muscle biopsies in this phase 1b study. And out of the 7 patients who did have a muscle biopsy, you can see that the gene expression of the same 3 genes that I showed earlier in the healthy volunteer limb immobilization study also increased at week 12 from baseline. Okay, so now I'm going to describe our ongoing pivotal study. This is a phase 2b study. It's also known as the STRIDE study. This is intended for registration as a single pivotal study. This is a randomized double-blind placebo-controlled study in contrast to our phase 1b study, which was a single-arm open label. So here there is a placebo control arm. The target enrollment goal is 200 patients, 1-to-1 randomization between the active drug arm and the placebo arm. What's also different from the phase 1b study is that this is intended as a 24-week study as opposed to a 12-week study. Another aspect of this trial is that we are offering an open label extension to all patients who complete STRIDE. This is called STRIDE Ahead. And here in STRIDE Ahead, patients who complete 24 weeks of dosing will be eligible to continue to receive Mavodelpar 100 milligrams once a day for up to 2 years. Oops. Okay, so the primary endpoint of this pivotal study is the change from baseline to week 24 in the 12-minute walk test. Our key secondary endpoints are looking at fatigue using the MFIS. A variety of other endpoints include assessments of muscle strength and function, such as a 30-second sit-to-stand test, step counts. We also have a variety of patient-reported outcomes, including the SF-36. We have other subscales of the MFIS. We have the PROMIS fatigue instrument as an alternative to the MFIS. We also have the BPI, which we had in the phase 1b study. And some of the key updates that I'm pleased to be able to present here at the MDA conference is, number one, we announced last week that our STRIDE study has now completed its target enrollment. We hit 200 subjects last week, and we are actually expecting to go over 200 subjects. So another thing that we recently implemented in the STRIDE Ahead program is we are offering nuclear DNA patients the opportunity to enroll in STRIDE Ahead. So in the STRIDE study, this is restricted to mitochondrial DNA patients. I mentioned earlier that of patients with PMM, approximately 70 to 80% of those patients will have a mitochondrial DNA defect as opposed to nuclear. But we think it is important to also, be able to study the safety and tolerability of Mavodelpar in nuclear DNA patients. And so a recent amendment is allowing for the enrollment of nuclear DNA patients in STRIDE Ahead. And then finally, with having achieved target enrollment, given that this is a 24-week study, we are expecting top-line data from the pivotal STRIDE study in the fourth quarter of this year. Okay, that's the end of my presentation. Thank you for your attention, and also thank you, Professor Hirano, for mentioning the UMDF genetic testing program. This is a really, I think, a great collaboration between industry as well as a leading patient advocacy group. We know that there's many patients with suspected primary mitochondrial disease and PMM, but at least in the United States, our understanding is that the majority of those patients have not been formally genetically tested, And so we think that hopefully will be a catalyst to getting, the definitive diagnosis for many of our patients. But thank you.
Just a simple question. Is there a reason that everybody's excluding pediatric patients when you actually might have more impact on them?
So the question was, is there a reason why we excluded pediatric patients? Yeah, I mean, it's a very good question.
All right, thank you. I'm Susan Van Meter with UCB Pharma, and I'll be talking about a very specific mitochondrial disorder called thymidine kinase 2 deficiency, or TK2D. I am the program physician for the TK2D program at UCB Pharma, and this program has been my life for the past several years. In terms of disclosure, I had to chuckle at Will's slide. You can tell that legal's involved in slide review because the number of words goes up quite dramatically. So first and foremost, I am an employee of UCB. The drug that I'll be talking about, doxecitine and doxribtimine, informally known as DoxTM, formerly known as MT1621, is an investigational drug. So as Dr. Hirano talked to you about, mitochondrial diseases encompass a wide variety of diseases. It involves defects in both the mitochondrial DNA and nuclear DNA, which makes it a very challenging disease to diagnose. The disease that I work with, thymidine kinase 2 deficiency, is one of the nuclear DNA depletion or deletion syndromes. So the mitochondria is involved in multiple cellular processes, but the biggest thing it does, it's the powerhouse of the body. It produces the energy, ATP, through oxidative phosphorylation. And to do that, it has to have mitochondrial DNA that is maintained and reproduced with fidelity. The thymidine kinase 2 enzyme is really important for that mitochondrial DNA synthesis. Mutations in the gene reduce the mitochondrial DNA synthesis, which then ultimately reduces the ATP synthesis. Symptoms of TK2D present primarily as myopathy. The myopathy tends to vary depending on the age of onset. And this gets to the question that was sort of alluded to earlier about different presentations by age. Age of onset is a very critical factor for this disease in terms of the severity of symptom expression and the rapidity of disease progression. Patients with an earlier disease onset tend to have a much more fulminant course. Patients with a later disease onset also have symptoms, but they tend to be more smoldering and more typically harder to diagnose. The hallmark of the disease is proximal muscle weakness. This tends to be the very first sign that's noticed, and then progresses to respiratory muscle weakness, ocular muscle weakness, etc. Other symptoms can be present, including CNS symptoms, seizures, encephalopathy, heart symptoms, liver and kidney symptoms. This is just an example of some of the myopathy that can be seen, the proximal muscle weakness, the facial weakness, the prototypical floppy baby, eyelid ptosis, the progressive ophthalmoplegia, and progressive dysphagia. Like a lot of the mitochondrial diseases, this has a very profound impact on patient lives. In adults with TK2D, there's the global physical and mental health issues, problems with physical function, pain, fatigue, anxiety, and interference with social functioning. For children, there are effects on mobility, pain, global health, and fatigue. In a survey done to assess patients' symptoms, both the physical and the psychosocial impacts, you can see that mobility is a huge issue for all patients. Fatigue, big issue. Respiratory function. The other symptoms also play a role. Impact on the psychosocial portions of the disease are also outlined. And if you just think about it, if you have a child with this disease and they can't even get up and get dressed in the morning or eat breakfast by themselves, how are you going to get them to school? So these are pretty impaired patients, both on a physical level and a psychosocial level. So the drug that I work with is composed of two endogenous compounds, doxecitine and doxribtimine. Doxecitine is deoxycytidine and doxribtimine is deoxythymidine. These two components are administered together as an oral solution to patients on a daily basis. What the drug does is take advantage of residual TK2 activity in this mitochondria, and it also uses a cytosolic pathway that involves a slightly different enzyme, the thymidine kinase 1 enzyme and the DCK enzyme, to help increase mitochondrial DNA production. A balance of both the two components is necessary to maintain the mitochondrial DNA fidelity. What we've found in preclinical models is if you only administer the deoxythymidine, which is the active component, you end up with mitochondrial DNA that is not as well suited to what it's needed for. And ultimately, the mitochondrial function goes down. So we have had a very non-traditional development program, to say the least. Because this is such a rare disease, trying to set up a study with 200 patients is really not possible. It's not because of placebo per se, but we're talking about patients with a fatal disease. And to do a study, to be able to measure survival, you need to do at least a 2 or 3 year study, even in patients with the most severe onset. So trying to recruit patients to be in a study on placebo for that long is very challenging. In addition, there may be different populations that may benefit differentially. So our program actually is focusing on patients with pediatric onset from birth up to an age of onset of 12 years. We've set up an external patient cohort called the Untreated Patient Database, or UPD. There are 2 retrospective studies, the MT1621-101 study and the MT1621-107 study. There's an ongoing prospective study that's open label where patients are receiving treatment. Of the original patients enrolled in the 101 study, 35 patients have cascaded into the open label component of the 102 study. The data combined from all three programs, the retrospective data collection and the prospective data collection, will be combined to assess treatment benefit. We're in the process of data analysis and anticipate results later this year. So UCB remains very committed to this development program, and we are very proud to be supporting the Mitochondrial Disease Community Foundation with education and genetic testing. We are on the path to seek approval for our drug from FDA and EMA in the coming months. So, as always, we do want to thank the patients, the family,